Welcome to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice.
On today's episode, we're focusing on biologic augmentation of rotator cuff tears, including an algorithm for determining which patients require augmentation as well as different augmentation approaches, such as extracellular matrix scaffolds and orthobiologics. As always, links to many of the papers that we discuss on the show today can be found on our podcast website, www.thesportsdocspod.com.
We are joined today by Dr. Brian Cole, a professor of orthopedic surgery and chair of the Department of Orthopedic Surgery at Rush University Medical Center, chair of surgery at Rush Oak Park Hospital, and section head of the Rush Cartilage Restoration Center. He's also a past president of the Arthroscopy Association of North America and a team physician for the Chicago Bulls and the Chicago White Sox. Welcome to the show, Brian. Thank you so much for taking time out of your very busy schedule to join us on our podcast again tonight.
I'm really happy to be here again. Thanks, Ashley and Catherine. I appreciate it.
Thank you.
Awesome. So at AOSSM, we discussed osteochondral allograft transplantation, and that was an awesome episode. So for our listeners, please check that out. But today we're going to be switching gears and talking about augmentation of rotator cuff repair. Now, before we get into your algorithm for determining need for augmentation, as well as some of the augmentation options that are out there, we want to first start with a current snapshot of how our rotator cuff repairs are doing. So you've obviously done a lot of research in this area of rotator cuff repairs. So over the last decade or so, how are our standard rotator cuff repairs performing in terms of clinical outcomes, but also in terms of structural healing?
Yeah, I think that's probably the best place to start because, when we think about the last 15 years of research, it was basically trying to create a thesis that was grounded in biomechanics that said, look, maybe we can do a better job at time zero. So we can add more anchors, we can add more sutures per anchor, we can add more rows and things of that nature. So we tried to optimize this biomechanical construct to the point where we think at time zero, we have the best possible opportunity for something to heal. And I think, when you think about rotator cuff disease, it's not unlike osteoarthritis or other degenerative conditions. Like rotator cuff pathology is extremely common. We probably have 7 million people running around over the age of 65 that have a rotator cuff tear. And in this country, we repair probably less than 500,000 for all ages. So that's because it's an attritional disease. So we shouldn't be shocked when we take poor quality, potentially degenerative or dystrophic tissue, put it down to bone. We do a great job. It's the best biomechanical construct. But 1 year later, we see a re-injury or rather a re-tear, or maybe it's a failure to heal in the first place because it's really a biologic problem as much as anything else. So I think, in general, when we look at how far we've come from biomechanics, at time zero, we do very well. I think re-tear rates have improved given our understanding of the anatomy in terms of structural integrity. I think we've learned that the absence of structural integrity is potentially a problem in terms of patient satisfaction. But that being said, we still haven't had major gains in terms of reductions in failure to heal or re-tears simply due to biomechanics alone.
Yeah, and Brian, you touched on that structural integrity and how does that affect patient satisfaction? So when we think about re-tear rates, we know that we have to do better, but we also want to sort of tease out like how much does it matter? Because there's some data out there that says they're still having some good clinical outcomes in the absence of structural healing, but that also doesn't seem to make a lot of intuitive sense. So how do you work through that data?
Yeah, I mean, it speaks to think about that large population of people who have rotator cuff disease who don't know they have it. So I think what happens is that we convert people who know they have it into those who don't know they have it by doing surgery for probably a variety of reasons, quite frankly, some that we understand and some that we don't understand. And I think you take a maladapted person who has symptoms, whether it's night pain or functional loss or weakness, we convert them to an asymptomatic state. And even in the setting of a failure to heal or a re-tear, they can still remain relatively asymptomatic. One of the problems we have is with our PROs or our patient-reported outcomes, there isn't a lot of sensitivity for strength and function. And the few scales that we do use that incorporate that, such as a constant score, for example, which about 25% of it is strength, we can then get some measure of objectivity. But in general, if you look at studies that have that have looked at strength and function, the most satisfied patients are those who have relatively normal strength and function. And the most likely to have relatively normal strength and function for sure is going to be someone with an intact cuff. Now, that being said, there's a lot of heterogeneity in rotator cuff pathology, and poor muscle quality does still can trump an intact cuff in terms of function. So it isn't very linear, but there's some general take homes. And I think the general take homes are that people can function very well with a torn rotator cuff. They may never know they have a rotator cuff tear. When they do know they have one and they don't get better with traditional non-surgical things, they can be made to feel better. And they may not be normal, but it may not be meaningful to them in the ways that they're not normal unless you look at it with some degree of granularity.
So you mentioned clearly structural integrity does impact functional outcomes and strength. So we obviously want to minimize the risk of those re-tears. And you kind of hinted to it at your first answer when we were talking about rotator cuff pathology as to the biology of the tendon structure, and maybe that's impacting why these don't heal. So can you discuss some of those biologic challenges that we are facing that impact structural healing of our rotator cuff repairs, even if all the biomechanics are intact?
Yeah, I mean, there's things that we can control and there's things we can't control. And we're getting much better at figuring out the things that are really important, right? So, and so, look, it could be smoking. It could be A1C and diabetes. It could be bone density. It could be calcium. It could be vitamin D. There could be certain protein deposition issues that lead to poor histology or dystrophic changes at the epiphysis where the tendon bone junction. Um, um, it could be chronic vascular disease. Like there's a number of variables that weigh into our ability to heal or our inability to heal. And I think unfortunately, only some of those we can control. So there's probably more biologic variables that lead to the demise of the tendon bone unit than there are actual structural material properties. But unfortunately, those are things that we largely can't control. And I think that that's why, you've seen a lot of our efforts and from a research perspective, say, look, if we're really going to make a difference, maybe we do have to focus on the biology because there's things that are not necessarily behavioral, okay, quit smoking, but rather intrinsic properties of the muscle tendon unit that might be in the bone, might be in the tendon, might be in the junction of the two, that if we could do better in that environment, then we can actually capitalize on good biomechanical structures at time zero. Otherwise, I think we're fraught with these challenges of trying to treat the problem in a biomechanical material way when we haven't done much for the structural properties of the tendon itself.
Yeah. And then, you've also spoken about before the chronicity of everything. We can't really change that. So, all those things are affecting it. But before we get into the surgical options, we want to that we have at our fingertips to address these biological issues. We want to dive a bit more into like your decision-making process. So obviously adding biologics or any sort of structural augmentation, it comes at a different, an additional cost, and not every patient might require this. So like, how do you start that? Do you discuss, can you discuss a little bit more your decision-making process on how you go through that algorithm?
Yeah. I mean, I think the first thing, and I think you were maybe hinting at this, is that um, a discussion of how to manage rotator cuff disease wouldn't be complete with the value of non-surgical care. When there's so much ambient disease out there, and it's funny because I have visitors all the time who will come to clinic with me and they see how I evaluate a patient with an MRI that shows a tear. And you and I know you can sort of date the length of time that a tear has been there to a certain extent based upon, the way the muscle appears, how much atrophy in the muscle, maybe interstitial fat between muscle fibers and so forth, the degree of retraction, the number of tendons involved, how the position of the head relative to the glenoid. Like there's all kinds of things that you and I can use as cues or signals for chronicity. And we tend to get people when they're symptomatic on top of a chronic pre-existing state. That's probably the most common situation. So you have to ask yourself, why are those people different than those who have the same pathology but don't have symptoms? And I think a lot of those people are just out of balance. I think there's evidence to prove that because when we repair a cuff and then it fails, or we put a balloon in the subacromial space for a chronic cuff that doesn't have much in the way of osteoarthritis with an intact subscap, those patients can actually get better for an extended period of time because I think what we're doing is we're resetting the balance across the shoulder so that they then behave like they're in their previous asymptomatic condition. So I do use a lot of non-surgical care, and I'm okay using occasional corticosteroid injections. I use a fair amount of physical therapy, and I use a lot of education because Patients can often come in, if you were to assess patient symptoms over time, and when they have shoulder pain, query them a month later, and they may not have shoulder pain. So, I mean, I can use myself as an example. I was heli skiing like 3 years ago, and I fell. I woke up the next morning, and I had like 2 days left, and I literally could not lift my arm. So I was like, well, if I really tore my cuff then, I would have known it immediately, right? But so it was bad, and I got a cortisone injection. Couldn't sleep. Same thing that all your patients complain of. Like, that's real, that's a thing. But I was living it. Maybe you guys have had some of these things too. And got better with an injection for 4 months. I had an ultrasound, not an MRI, because I knew I would find a tear. Did an injection again. After my third injection, 14 months in, because I didn't want an MRI because it wasn't going to change my judgment,
Yeah.
because I didn't think I just tore my tendon at that time, right?
Yeah.
I would have had a lot of pain. I didn't until the next day. 14 months in, doing bands and things like that, I was better. And I don't want to jinx it, but it's been over 2 years now where I've had no shoulder pain, no problem. So we tend to catch our patients at their worst. So let's assume that a patient enters into the algorithm that their symptoms are meaningful enough, they require treatment, the initial non-surgical treatment in the setting that I'm describing, where it's likely chronic or acute on chronic, and non-surgical treatment has failed, and for whatever duration of time you decide to do with your patient, then they enter the surgical pathway. And I don't think everyone needs augmentation. I would say acute tears with healthy biology, like truly acute tears, those patients may not have the severity of biologic issues, right? They may not have the same challenge. And I would argue that they probably have some, otherwise they wouldn't tear. But there are truly traumatic tears that you and I know are new, that have minimal retraction. You can just tell the physiology looks normal, but for the fluid between the tendon and the bone. And those are patients in general that it doesn't even cross my mind as far as being candidates for augmentation. And when I say augmentation, keep in mind that this could be, autologous orthobiologics, which might be PRP, it might be bone marrow concentrate. Some people might choose adipose, sort of dealer's choice, or it might be something that you add structurally, such as extracellular matrix of some sort to augment healing. And they function by very different means, and they might be very complementary. But how you decide who's going to go into that algorithm gets to be increasingly complicated based upon these biologic variables.
Yes, you predicted our next question. That's the next one, is talking about those options that we have for augmentation. And as you highlighted, it seems we have both scaffold options or extracellular matrix types options, as well as orthobiologic options. So we want to start with the scaffold options. Could you review quickly for our listeners the current scaffold options that are available to surgically improve biology? And is there one that's your go-to? Is there one that you prefer over the others?
Yeah, there's been a number of options. There's been xenographic options, there's synthetic options. I've been interested in kind of all of these, and I've seen the whole gamut back in the days when we had porcine, period, probably before you guys might even remember, it was porcine intestine basically that was purified, presumably had the antigens removed, that still we believe maybe had some xenographic or antigenic response, right? Then some of us were interested in synthetic options, which frankly I think makes a whole lot of sense. If it's a non-hostile environment, there's a synthetic option that tissue can grow into, that it creates fibroblast activity and scar deposition and things of that nature. Sort of like, think about if you hem your pants, where you may have a liner on the inside to maintain the structural integrity of the hem. If you could beef up that tendon in some permanent way, that kind of makes sense. We know that there's purified Achilles tendon. That's more of a matrix that might, in theory, maybe is less about structural strength or time zero biomechanics, but maybe more, as they claim, to be inductive in nature. And then there's grafts that are very strong out of the gates that may have conductive and inductive properties, such as dermal grafts. And I think when you look across the board at all the different options, I would say that the dominant treatment strategy today, based upon what industry brings to the table and what literature supports, both in animal models and then in clinical assessment with prospective evaluation for primary revision cuff repair, I would say the dermal allograft tends to be kind of dominate the picture in terms of clinical adoption.
If you're looking for a trusted name in allograft transplantation and want to learn more about your allograft options, then look no further than JRF Ortho.
JRF Ortho is an innovative leader providing the widest array of pre-sutured tendons, including the only BTB pre-sutured tendon on the market. Plus, they are the first to offer OCA cores available in 10mm, 12mm, and 16mm sizes for small focal osteochondral defects.
JRF Ortho also prides itself on superior customer care, making your ordering process JRF Ortho easy. They are committed to accommodating your needs, usually delivering an osteochondral allograft around 30 days, all on your terms. So if you're tired of waiting weeks for a condyle or waiting on a back-ordered tendon, reach out to JRF Ortho to find out how you can get your allografts in a timely manner.
And the most amazing thing is that JRF Ortho aims to give you one less thing to think about, so you can just focus on what matters most, your patients.
So discover the only allograft company focused solely on sports medicine. Order your allografts today with JRF Ortho.
Okay, so let's move on to surgical technique. Obviously, Brian, you have a great breadth of experience that I think that's really what our listeners want to hear about is just like there's been a lot of evolution over the years. So talking a little bit about augmenting your rotator cuff repair, how do you do that technique wise and what have you learned? Like, what are sort of like your little things that you can kind of share that help make us all better?
Yeah, so I think one of the biggest challenges in the past was whenever we were doing augmentation, we were often telescoping these grafts down sutures where we were passing the sutures to the graft outside the shoulder and then trying to get it in and lay it down and get it uniform across the top of the shoulder arthroscopically. And I have found that traditionally, whenever I had a reason to, that I could find a reason not to do it, I would not do it because it was just painful and unpredictable. So until it became easier, I was doing it rarely, even though I think some of my patients, possibly could have benefited, but the whole thing could turn into a mess if it's not, done efficiently. So you had to weigh that. And plus it was very expensive. We've also learned that you can do onlay on top of the cuff with some of these more inductive collagen agents and still get a pretty good result in terms of thickening the tendon and maybe maintenance of structural integrity. So, there are several ways to do this, and it could go between the tendon and the bone. It can go as an extension of the tendon to the bone, or you could repair the cuff and put it on top of the tendon bone construct where you have it integrating with the tendon on top at the muscle tendon junction, and then also going into the bone with independent fixation from the rotator cuff repair. That's been my go-to technique of late. And I've done all of these, and I felt that probably the best technique, this is with confirmatory MRI, has been was based on what some of the canine studies showed us. So Jimmy Cook did a wonderful, pretty elegant study looking at putting the graft on top of the cuff using dermis compared to other graft sources, including xenograft, and found that the best integration happened when it was on top. That from a structural integrity point of view, and as well as lameness, believe it or not, in a canine model, and by MRI analysis and structural analysis. So I'm pretty comfortable at this point saying that putting it as an augmentation for someone you think is at risk for potential failure is a reasonable way to do it. And there are now technical platforms that have been developed around this. So the platform that I use is CuffMend, which has been developed by Arthrex, but there are other companies that have some similar platforms. And the graft itself is introduced with an inserter, and the inserter stays within the shoulder while you can view lateral or view posteriorly and put it in laterally. And using an all-suture fixation device medially in the muscle has become very easy and cost-effective. And then you can either use the anchors laterally to sew it down to the bone, or separate anchors that are placed more posterolaterally or more anterolaterally.
So, Brian, the data is clearly there demonstrating a positive impact of dermal allograft augmentation on the healing of rotator cuff repairs. But cost is always a concern. I know, we all operate at surgery centers. I operate at a physician-owned surgery center. People don't want to shell out a lot of money for some of these grafts and patches unless they see there's a really cost benefit to it. And cost is always a concern for all sorts of healthcare systems. So you and your team at Rush studied this, the cost effectiveness of augmenting a rotator cuff repair with a dermal allograft patch. Can you talk about what this study showed in terms of the cost effectiveness?
Yeah, so these cost effectiveness studies are kind of all in the eyes of the payer. So I would, what we set out to do is to say, look, if you consider the cost of failure in the equation of time zero costs, is it really cost effective to the system? And we showed that the current price, which I think is around, it's less than 4,000, it's between 3,500 and 4,000, is about 25% of what the system could tolerate when you take all these the quality of life indices into consideration. So it's cost effective by what econometric experts would say. That being said, you and I typically are not feeling the brunt of downstream risk in the setting of failure. The insurance
Right.
company is. So while I can tell you objectively by the way that we typically look at cost effectiveness, the operation is considered cost effective. But you who own a surgery center may have a different lens. And
Yeah.
what I would suggest is that you could work individually with payers. You can. There are a lot of contracts that we have with carve outs because you're using an allograft. That's probably the bulk expense. The whole implant system that I use I think, is around $37.50, if I'm not mistaken. Okay, so and there is another more cost-effective way where you can actually use the biceps tendon in what we developed as a biceps press that can give you a 25 by 25 by 1 millimeter thick piece of biceps to augment the repair, and that can be useful, and that costs nothing. So, other than the anchors that you use. So I would argue, while I can tell you it's cost effective by the things that we study, and can publish, I would tell you that in your surgery center, it may be helpful if you have allograft carve outs, for example, for ligament reconstruction of the knee.
Mhm.
A lot of your insurance companies will pay for allografts. If you're in a cost plus or purchase order plus pricing arrangement, you may be able to get payment for your allograft tissue. And that's the way we've approached it. And we've done that with all of our payers, and we're successful in most, but not all. So we do some selection bias in terms of where we operate based upon this. I will say, though, it's not a crazy cost. And when you look at most reimbursements for rotator cuff, while it may eat into your margins, I think you're weighing, sort of less facility fee against an improvement in patient outcome in the right selected patient. That's a revision patient. That's someone who has these a Rohe score, which is an index that basically looks at bone density, it looks at the number of tendons, chronicity, degree of retraction, and those kinds of features that can predict whether or not someone's going to fail. And that paper is, really shows in a predictive way that once you accumulate a number of those variables, that patients are likely to fail structurally. And if you knew that, and if you could do a better job at selecting your patients, the truth, our decision making would be somewhere in between. We say, look, we're not going to do as well for the facility, but we're going to do better by the patient. But it's not going to be a money loser. And I think that's the reality in a setting where, especially when you can't get allograft reimbursement for augmentation for rotator cuff repair.
Yeah, I think that's really helpful. And, oftentimes if we don't get involved and put those types of studies out, people would get lost in the details and don't really understand the full picture of, how these graphs can be helpful, how we can still use them. So I think that's great work that you guys are doing. And, we certainly as a field appreciate it. So in addition to these scaffold options, we also have orthobiologic options to improve rotator cuff healing. So, PRP, bone marrow concentrate. How does that sort of fit into your practice at this time to augment rotator cuff healing?
Yeah, so I can give you sort of the elevator pitch on this one.
Yeah.
What we know is that, or what we think we know, is in culture, leukocyte poor PRP and diseased rotator cuff tissue does a better job than leukocyte-rich PRP in terms of tenocyte cultures. We know that in clinical studies that you'll be able to identify a number of studies that when they do show a difference for small and medium tears, you might see an improvement in structural integrity at 1 year. So that's small to medium tears. We also know, and that's just a single injection given at the time of surgery. We also know that concentrated bone marrow, based upon a study done years ago by Hernigow, showed a tremendous difference at 10 years when patients received bone marrow concentrate at the time of rotator cuff repair compared to those who did not. That study was almost unbelievable in my mind because the numbers were so staggering. It was like an 87% success rate. It was crazy. And at 10 years when people used it. So we repeated that study with a standardized single tendon tear, multiple investigators, 50 who got bone marrow concentrate, 50 who did not, MRI at 1 year. And we showed a substantial improvement by Sagaya scoring from like 57% with high grade changes down to about, 18 or 19% with high grade changes. So by MRI, we actually showed, and I honestly didn't think we would show a difference. I mean, we're just simply drying the field, injecting it underneath the tendon, and there's no placebo effect here because this is just MRI. Clinically, I would tell you that anecdotally, patients who receive it often, in my physician assistant, we call all of our patients the next day after surgery to see how they're doing. They swear they can tell who got it and who didn't just from post-op pain. Now, that is that is level 5. That's anecdotal. I will tell you, clinically, we saw some improvements in the patient who got it versus those who did not. Finally, there's some data that shows that adipose tissue might actually show a difference, but those studies are really small series, and there's been no publication that's shown that they've reproduced it, but they've shown with stromal vascular fraction using adipose tissue that there's been some benefit as well in terms of reduced re-tear rates. So, tying it together, the challenge is that orthobiologics using in the operating room is a non-reimbursed, essentially cash pay phenomenon for patients. So that's a whole other topic that if you ever want to talk about that one, how do you manage the orthobiologics from a business perspective? But there's coding and compliance issues and so forth. So until it's free or it's covered by insurance, we're very selective in terms of who we offer it to, and we're never arm wrestling patients over this. We're trying to be very, very fair and unbiased in our presentation. But I would argue that if you had to say what the holy grail is, from what I think I know, I would say augmentation with a dermal graft, along with bone marrow concentrate, proper rehab, good surgical technique, maybe a little bit of luck. Those are patients who are most likely to do well in 1-year follow-up with MRI imaging in terms of structural integrity, and hopefully clinical outcomes would follow suit.
I like how you put that, the holy grail.
Yeah.
Exactly.
Yeah, it's just,
Awesome.
we got to balance all the economic issues and patient demands and everything else. It's not, you and I don't control all the decision making, but, in a perfect
Yeah.
world, I think there's some data that would support that algorithm.
That's excellent. Well, thank you. You actually answered our last question, which is what do you want our listeners to leave with here today? But that was an awesome summary of what they should take away. So thank you again so much for taking time to join us tonight and answer all these questions. It was really awesome.
Thank you, Ashley. Thank you, Catherine. I appreciate you having me on, and best of luck to you.
Thank you.
Thank you. We really appreciate all your insight, and we know how much people value, hearing your expertise and everything you've learned from your research over the years. So thank you.
Yeah.
You're very welcome.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or a comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. No S. We love your feedback.